Hello, I'm Valerie Rojas, the Suicide Prevention Coordinator at the Washington, D.C. VA Medical Center. Welcome to the Washington, D.C. VA Medical Center. This is suicide risk management training for the clinical staff. The intent of this training is to provide VA nursing staff and any other staff with the necessary information to recognize and to bring into treatment veterans and individuals who are struggling with suicidal thoughts. The objectives are as follows: to understand the scope of suicide within the United States, understand the terminologies of knowing self-directed violence, understand the scope of suicide, veteran-specific suicide data, myths, Operation SAVE, is path warm, know how to identify a veteran who may be at risk for suicide, know what to do when you identify a veteran or an individual who is at risk for suicide, recognize the importance of what is termed means restriction, and be able to develop a safety plan. As you can see, suicide in the United States is a significant problem, with over 41,000 people killing themselves in 2013. Suicide is the second leading cause of death among people aged 15 to 24 and 25 to 34, and the fourth among persons aged 35 to 54. On an average, 22 veterans a day commit suicide. Traumatic stress, major physical injuries and loss of relationships, a high level of deployment stress, and mental and physical disabilities are associated with an increase in suicide rates. These are the latest statistics we have from the Centers of Disease Control and Prevention. Please remember that on average, 22 veterans a day commit suicide, and suicide is everybody's business at the Washington, D.C. VA Medical Center. As you can see, suicide in the United States. Suicide among males is 4 times higher than it is among females. Females are more likely to have suicidal thoughts than males. Firearms are the most commonly used method among males, and poison is the most common method for females. Self-directed violence is behavior that is self-directed or deliberately results in injury to oneself. Suicidal intent occurs when there is evidence that at the time of injury the person intended to kill him or herself, and that the person understood the consequences of their actions. Self-directed violence is behavior that is self-directed or deliberately results in injury to oneself. Suicidal intent occurs when there is evidence that at the time of injury the person intended to kill him or herself, and that the person understood the consequences of their actions. The first bullet point on this slide, you might be thinking, how can suicide be interrupted by self? It actually can be, and this occurs when a person actually interrupts or stops the suicide by themselves. And we actually had an incident where a veteran tied a cord to a doorknob, tied the other end of the cord to his neck, proceeded to hang himself, and then changed his mind in the middle of the act, thankfully. So this is a suicide that was interrupted by self. Physical injury is self-explanatory. I don't need to explain that. Suicide also is self-explanatory, but what I do want to point out is that suicide is a death by self-inflicted injury with the intent to die as a result of the behavior. Thank you. Understanding suicide. It's important to understand the dynamics of suicide. Suicide occurs when psychic or mental pain is unbearable. People actually seek out death to deal with the mental anguish of pain. We have to understand that everyone has a different threshold for dealing with psychological pain. What's important to understand and what I want you to remember is everyone who commits suicide absolutely feels driven to it. Veteran-specific data related to suicide. Over 100 veterans commit suicide each week. I want you to keep this in mind as you serve the veteran population here at the Washington, D.C. VA Medical Center. I'm not going to read all of this information right here because it's in front of your faces. But what I want you to also remember is the rates are much higher than they were 20 years ago. And this is directly attributed to the wars in Iraq and Afghanistan. And we have several veterans who served in these wars. You probably already received some of this information about the contributing factors related to veteran suicide. If some of you missed this in onboarding, I'll just go over it again for you very quickly. Duty assignments. Can you imagine being deployed several times and how that interrupts relationships with your spouse, family members, or friends? Body image disturbance. A lot of our veterans here have lost limbs and have several disabilities, wounds, and oftentimes people stare at them, maybe not so much in our facility because we're used to it, but outside in the real world. Social status. You can have veterans here who have been colonels and have had high positions in the military, or who have been combat veterans and who have been have had different high status positions, and now they don't have that, and they are here listening to other people telling them what to do, where to go, and when to do it. Loss of physical functions, death of a loved one, overall loss of self-esteem, and just thinking about how their view of the world environment has now changed. And think about that, how it has impacted us with all of the recent attacks and terrorism that we see in the world, and people of different ethnic backgrounds. So there's a lot to take into consideration for everybody. So these are a lot of the factors that contribute to veteran suicide. Asking about suicide may lead to someone taking his or her own life. This is absolutely false. It is a myth. Asking someone about suicide gives them permission and gives them a comfort level to share their thoughts and feelings, and helps to open up dialogue. Myth or reality? There are talkers and there are doers. Most people who die by suicide usually have communicated some intent. So actually there are talkers and there are doers. There are people who absolutely have not communicated any intent to commit suicide, but that is usually, they are usually the outliers. So typically there is some type of communication, and sometimes we don't find that out until, unfortunately, after the fact and after it's too late. So that is true and false. Most people who die, if somebody really wants to die by suicide, there is nothing you can do about it. There is always something we can do about it. Usually when a person is about to commit suicide or thinking about committing suicide, they're in a crisis, and crises are often time limited. So if we can help them to survive the immediate crisis, then we are able to help them not to commit suicide. And a lot of suicide is driven by depression, and there's medication for depression, medication for schizophrenia, and other mental health disorders. So we have to bring people into treatment, get them care. But again, the biggest thing is that it's a crisis. We can get them through a crisis by giving out the number to the crisis line, being available, and listening to them. So yes, there are things that we can do to prevent suicide. There is always something we can. He or she won't die by suicide because they made plans for a vacation, they have young children at home, or they have made a written promise, or they know their family loves them. It doesn't mean anything that they've made plans for a vacation. We had a veteran who actually made plans for a vacation, made plans for Christmas, and still committed suicide. Have young children at home. Nothing is a guarantee, but we do the best we can to avert the crisis. I have deliberately made a verbal or written promise because we do not use a contract for safety. But every now and again, this still pops up, and I want you all to know that it will not hold up in court. It is not legal, because what we are effectively asking is someone who is not in their right mind to say that they're not going to kill themselves, and that makes absolutely positively no sense. There is no such thing as a written or verbal contract for safety. So it is a myth that they won't die by suicide by any of these reasons. It doesn't mean anything. Everybody should have had Operation Save when you were in onboarding. It is pretty obvious. I'm not going to go over this. You can call me and I'll give you my contact information at the end of this. We will move on to assessment and referral. The slide 21, you can pretty much read for yourself. It's pretty self-explanatory. I'm skipping to slide 22. For the first three major warning signs are pretty obvious. Someone threatening to kill or hurt themselves, looking for obvious ways to kill yourself, which we have already gone over, pills, weapons, or any other means, and some people have preferred means. We will actually discuss in means restriction, and talking or writing about death or dying. For the first three. The next slide just gives you a little bit more information about is path warm. What you want to focus in is about the seventh bullet point down. Any recent discharge from an inpatient hospital is something that you really want to pay attention to, because studies have shown that people who have recently been discharged from an inpatient psychiatric unit also are at greater risk for attempting suicide. So you want to know that as well. What you want to focus in is about the seventh bullet point down. Any recent discharge from an inpatient hospital is something that you really want to pay attention to, because studies have shown that people who have recently been discharged from an inpatient psychiatric unit also are at greater risk for You want to be able to ask questions, not to be judgmental, and show empathy. You can say something like, I appreciate that this is difficult for you, and I've known other patients who've had similar challenges. I just wonder if you have had any thoughts about hurting yourself, or have you ever attempted suicide before? This slide has quite a bit of information on it, but what's important to remember is you want to ask them about timing. For instance, how much time have they thought about thinking of suicide? Want to know what things makes it better or worse? Have they been hoarding medications, or how long have they been hoarding medications, or how long have they thought about a plan? Have they been rehearsing any type of plans for suicide? Just to go back to that slide, just want you to know when we were talking about behaviors, it's also important to remember that the VA does not recognize gestures, so we're always looking at behaviors. You need to remember that. So we're looking at the behavior that a person engages in. Why is it important to ask about a history of attempts? Most people attempt suicide one time, but about 16% repeat within 1 year. And when they repeat, usually the attempt is going to be by more lethal means than the first time. And approximately 2% of attempters die by suicide within 1 year of their attempt. Responding to a crisis, we discussed before that a crisis is time limited, and it is a response to a very stressful situation. And people are in crisis usually use some type of maladaptive behavior. So what we want to do is to lessen the intensity, duration, during the presence of the crisis. You want to change the focus from an emergency to a more understandable and doable type of a situation. You want to protect the person from self-harm. You want to give them back control and help them to be able to cope through and reinforce healthy coping skills for the person. Reestablish equilibrium or balance and help them to feel like they're safe and secure. Also, what you want to do is make sure that they are safe. If they're talking about any form of suicide, you don't want to leave them. You want to make sure you get someone to assist you, notify your supervisor, get 911. I'm sorry, not get 911, but you want to notify your supervisor, notify the VA police by telephone. You want to have that person with you in arm's length at all times, and implement the emergency response system here at the Washington VA Medical Center. Moving up to means restriction. The idea behind means restriction is to delay the time between the impulse and the person obtaining their preferred means or method of suicide. For an example, we have gun locks that we give out to our veterans. Some veterans or people actually prefer death by suicide. So our thought process is, and evidence shows that it actually works, the veteran will use the gun lock by putting it in through the gun, the barrel of the gun, or the trigger of the gun, and impulsively they may decide they want to kill themselves by gun. By the time it takes them to unlock the gun, find the key to unlock the gun lock, that they would have thought, gee, do I really want to do this? And actually, it has worked. Several of our veterans had shared this with us. So the goal is to restrict whatever means the veteran wants to use or their preferred means to commit suicide. That is the idea behind means restriction. Safety planning. Safety planning is a plan that is implemented pretty much by the veteran with a clinician. The idea of this is that when a veteran is feeling suicidal, that they're able to pull out that plan and be able to implement the coping strategies that they have already identified to help them not to commit suicide. So there are 5 steps to the safety plan. They are for the veteran to be able to recognize the warning signs, use coping strategies, socialize with family or friends or other people who may be a distraction from the crisis, contact family members, friends, or professionals to resolve the crisis, and last but not least, actually contacting the professionals like the Veterans Crisis Line or agencies or suicide prevention program staff. And when the safety plan is done with the veteran, a copy of it is given to the veteran, because during the time of crisis, people are not thinking straight. They actually need to go and pull out this plan and read the plan, and it's a guide for them so they know what to do in a crisis. And our veterans from suicide prevention have actually shared with us that this has been helpful for them, and it's actually worked, and they have called the crisis line or called family or friends or suicide prevention to get them through the crisis and prevented them from engaging in suicidal behavior or committing suicide. Safety planning. I'm sorry I couldn't be with you in person. If you have questions, do not hesitate to call me. My extension is 54999. My name is Valerie Rojas. I am located at 3A103. Take care. Enjoy your stay with us at the Washington, D.C. VA Medical Center. And for anyone who is a veteran, thank you for your sacrifice and service to the country. Have a great day. Goodbye.